So I think it is time for us to get started. I am Lajos Pusztai. I lead the breast medical oncology group at Yale University and also co-direct the genetics and genomics program. I would like to welcome you to this panel discussion on how to select patients for extended adjuvant endocrine therapy. So I would like to welcome you all, and I hope that you will enjoy these three presentations and the discussion after the presentations, as well as the lunch. So I will start with a small introduction why this is an issue that we all face in the clinic. So you're all aware of the 5 randomized clinical trials which compared 5 years of endocrine therapy versus an extended 10-year adjuvant therapy, either with the continued use of tamoxifen or switching from tamoxifen to an aromatase inhibitor. So each of these studies showed a remarkable piece of data that you probably are all aware that approximately half of all recurrences of ER-positive cancer happen after the first 5 years, after 5 years of endocrine therapy. All 5 of these studies showed a small but significant decrease in late recurrences with the use of extended endocrine treatment. So the ME17 randomized patients after tamoxifen to letrozole. The NSCB-B33 had a very similar design, but used exemestane after 5 years of tamoxifen, and was analyzed after a shorter accrual period than was expected. Nevertheless, showed a trend for improvement with extended therapy. And the ABCSG-6A trial again showed a significant improvement in recurrence-free survival with extended therapy. And the 2 tamoxifen trials, Atlas and Atom, again showed a highly consistent result, indicating that extended adjuvant therapy is a good thing. However, so this comes with costs and side effects. So this is data from the Atlas trial, and it showed an improvement in breast cancer death with the extended therapies. However, 340 patients have to be treated to save 6 lives from breast cancer death. And it came at the extra cost, or the additional cost, of 3 additional endometrial cancers and a pulmonary embolism. This really drives the importance of the question of how we select patients who really need the extended adjuvant therapy and spare probably the vast majority who does not need the cost, the toxicity, and the inconvenience of extended therapy. So to make the most clinically useful decision, you really need to understand 2 components to this. One is the risk. So you have to be high risk for recurrence, but also you have to be sensitive and benefiting from additional therapies. So these are 2 subtle, there is a very important subtle difference between these 2 important parameters that you need to factor into the decision making. So someone could be high risk, but may not benefit from therapy. So think about an ER-negative patients with multiple lymph nodes, high risk, but we wouldn't treat them with tamoxifen because they would not benefit from it, despite being high risk. So to date, tools which actually help us to make this decision, but which ultimately all face at the 5-year mark, are very sparse. Oncotype DX has been tested and unfortunately doesn't really predict well for late recurrence, and doesn't really predict either whether patients will be sensitive to extended therapy or not. So most of the decision currently, I think, what is based on clinical pathological features, which are again help to some extent predict late recurrence. Larger tumors with more positive nodes are at increased risk for later recurrence, and this risk continues over time. However, these clinical parameters provide no information whatsoever about sensitivity to therapy. So the ASCO and many questionnaires which asked physicians and asked us about what we consider to be highly important biomarker questions to be solved, identified this particular problem as a high priority sort of translational research question. How we predict late recurrences and sensitivity, continued sensitivity to extended endocrine therapy. Presented here probably first in 2011. So a couple of years ago, my group made a really interesting observation that we presented here probably first in 2011, that you can use proliferation and estrogen signaling information, and you can combine them in a way that you can identify late recurrence. So what these curves show is that if you have a high proliferation and very low ER status, then you recur rapidly. And then actually, if you recurred in the first 5 years, you have really low risk for recurrence later on. But the other three groups, which are the combinations, so the estrogen receptor and proliferation signaling, actually behave very differently. So you can pull out a very, very low risk group throughout the 10 years. But there is another intermediate group that actually becomes high risk after 5 years. So this is not an assay, but it shows you the principle that you could use these parameters to really create a clinically useful assay. So this brings me to the breast cancer index, which is a test which combines information from proliferation and estrogen signaling. So the proliferation component relies on 5 cell cycle-related genes, which really are components of the molecular grade index and relate to genes which drive the cell cycle and are highly prognostic in multiple independent publications over the past like 10 years. The estrogen signaling component is the ratio of 2 genes, HOXB13 and IL-17. These also carry a dual function. They are prognostic, but totally independent and unrelated to proliferation, and at the same time carry some predictive value as well, that is sensitivity to endocrine therapy. So the breast cancer index combines these 2 types of information from the mRNA expression of these genes. So it provides prognostic information for 5 to 10 years and provides predictive information again across 5 to 10 years. The prognostic information comes from the combined use of the proliferation and the 2-gene ratio, whereas the predictive information comes from the 2-gene ratio. And it's reported separately. So that's what makes it really sort of useful and user-friendly to can gauge at the same time the risk of recurrence after 5 years and also the expected benefit. So the next few slides, I will show you the data that supports this. So the secondary prognostic risk stratification value of the breast cancer index has been shown and published in 3 separate independent studies. 2 of these include randomized trials and archived specimens from randomized trials, and one of them is a multi-institutional series. These publications are available for you at the back of the room. So the first study is a Swedish randomized trial which took ER-positive patients, and they got no therapy or tamoxifen. It's an old trial. And the other randomized trial is the ATAC, the trans-ATAC component of the ATAC study. And in totality, these included about 1,300 patients. So this slide shows you the results from the largest study, the trans-ATAC, and it recapitulates the result from the other smaller trials. What you show here is the cumulative risk of recurrence, distant recurrence, in the first 5 years and 5 to 10 years, based on the breast cancer index risk categories. So the blue line, the bottom line, is low risk. The red line is intermediate risk category, and the green line is the high risk folks. So you can see that the low risk group remains low risk throughout the 10-year follow-up period on which the data is based. The high-risk group also remains high-risk, but the important thing is that the intermediate risk category flips over. So the intermediate risk, people who are intermediate risk or relatively low risk for recurrence early on, they actually become high-risk in the remaining 5 to 10 years of follow-up. Another important piece of information on this slide is the distribution of the risk categories. So a little over half of patients are in the low-risk group. So that's the group that has such a good prognosis that you probably wouldn't really want to treat them beyond 5 years because their risk of recurrence is really low. However, there is another remaining half who is high risk, but are they sensitive to endocrine therapy? So the trans-ATAC study, as you are well aware, also tested the predictive and prognostic values of the IHC4 test and also the Oncotype DX, the commercially available test. And both of these actually lost the predictive and the prognostic value for the late recurrences, and this is what's shown on this slide in terms of the hazard ratios predicting late recurrence. This is a summary of the 3 studies that I refer to. So I've shown you the slides, the cumulative risk of recurrence for the ATAC, and this also shows you the risk of recurrence in the low risk and high risk categories for the remaining 2 studies. So the results are highly consistent. So the 3 bars stand with the 3 different colors for the 3 different studies, and the low risk groups have about a 2 to 3% risk of relapse in the 5 to 10 year period, whereas the high risk group has a 10% or greater risk of recurrence. So the next important question is, so we identified the group that is high risk, but do they really benefit from extended adjuvant therapy? So this question was studied in the MA17 study. And the component of the breast cancer index that's used for that prediction, or that was tested for predictive value, is the H/I component. That's to remind you to the MA17 design. So it was 5 years of tamoxifen, re-randomized to letrozole or placebo, and the study showed a 4% improvement in recurrence-free survival. And of course, it brought in additional toxicities and risk of osteoporosis. So this is the flow chart of the study, which included the patients who had available paraffin blocks from this trial. So of the 5,000 patients, 319 relapsed. Out of these 319, 100 had tissues that could be recovered, and 83 of these tissues actually yielded informative material for the test, that is RNA. And to make this study sort of feasible and yet statistically still sound, it followed the case control design. So all the recurrences were included as the cases, and they were matched 2 to 1 to controls, which did not have recurrence, and they were matched for age, nodal status, and T-stage. So the question was whether the H/I ratio could predict who were the ones who really benefited and avoided a recurrence because of the extended adjuvant therapy. And these are the results. So if you group the patients into high and low risk, then it was the high risk group which actually really drove all the benefit from the extended therapy with letrozole. So that was a 16% absolute difference in the risk of late recurrence, which is about a 70% decline or a 70% drop in terms of risk. And there was no significant benefit in the low risk group, which you would expect because the events are really rare there. And this interaction between the test result and the outcome was significant in a proper statistical test, which is called an interaction test between the biomarker, treatment, and outcome. So this is a multivariate analysis that shows that the H/I result remains significant after you factored in the tumor size, grade, and nodal status and age, and the other routine clinical variables for the patients. So in summary, the breast cancer index combines biomarkers that assess proliferation and estrogen signaling. The combined use of these markers can predict both the risk of early and late recurrence and also sensitivity to endocrine therapy. The ability of the breast cancer index to predict risk of recurrence both between 0 to 5 and 5 to 10 years have been validated in a series of archived specimens from at least 3 independent patient cohorts, including 2 randomized trials. And the breast cancer index is currently the only test that has also been validated to predict benefit from extended adjuvant endocrine therapy in the MA17 trial. I also put up for you a report which shows you how the results are presented. And basically they are presented the way I described it to you. You get both the risk of recurrence in an absolute numerical value. So this particular instance, the risk of recurrence is about 8.6% or something like that, and also the likelihood that the person would benefit from extended therapy. So with this, I would like to give the podium to Dr. Dennis Yardley, who will put this into into a clinical context for you, and we'll present some cases.
Interesting next segment, because I think also set up very well how this index has come to being. So I'll close with a couple of cases and just kind of give a little bit of a clinician's perspective of how I've utilized it or how this may be actually integrated in practice for any given patient. So I think, as we've covered, one of the biggest issues with the hormone receptor positive patients in the adjuvant setting is trying to determine this risk of recurrence. And I think patients come in to your clinic as well as mine with really parading around that 5-year mark. And for the hormone positive patients, I always cringe a little bit because I always have to put that disclaimer that still 50% of the risk of recurrence happens after year 5. I think it's a different story now for the triple negative patients, where I think a 5-year disease-free interval has become more impactful and quite meaningful, and I think the risk for that group is quite small. So when we see the risk of recurrence that really remains for our hormone receptor positive patients, and now in the context of some of the data with regards to the trials that have shown benefit from extended therapy, I think the question really becomes, is this a recommendation then that is for all patients, and how can we perhaps tailor it? There are some patients that I think cheer when they get to that 5-year mark and are ready to ditch their endocrine therapy, and there are other patients that have a fear of going off. That's sort of their security blanket for keeping their disease away, because after all, for the 5 years they've been taking it, they've remained disease-free. So I think that always factors in when I have these discussions with the patients. So, when we look back and I now approach the patients that come into my clinic and try to really assess where we are with our data, here's a list of the trials that really show what is that benefit. I think patients and myself as a physician sometimes inflate what the benefit really is. We're always cheering when there's a benefit, a potential way to improve outcomes from our patients, but I think it's very important to really dissect what is that specific outcome. So you see here the MA17 data that Dr. Pustai has just kind of covered, our Austrian group, and then the 2 more recent reports with tamoxifen from the Atlas and Adam trial, really showing that there is a group that benefits from extended adjuvant endocrine therapy. But when you look to the column marked off in yellow, you can kind of really see in absolute benefits. If you had a group of patients lined up, it still isn't quite a home run, but it's the best thing that we can now offer and discuss with the patients. But the absolute benefits really is less than 10%, so it's 3 to 6%. So it is worth a discussion with the patients, but also getting in lots of other factors into trying to make these decisions. So when we look at making these clinical decisions for our patients of whether to extend their endocrine therapy or not, I think we really embrace now what are the risks of these treatments and what are the potential benefits as covered. We have many now randomized trials that show extended benefit for endocrine therapy, and a few that are still waiting to report results, like the NSABP 42 with extended aromatase inhibitor therapy. But I think, again, the amount of patients that are to benefit are modest. And if you look at the Atlas trial, which is published, you can't really identify a subgroup that didn't benefit. So it wasn't just the lymph node positives, it's the lymph node negatives, it wasn't tumor size, it wasn't age. All of them benefited. So do we extend this recommendation for all of our patients on endocrine therapy? And I think it's a real challenge and struggle, both as a clinician and for our patients. I think the other balance feature is there are risks with these therapies to be prolonged as well. It's always a win-win if there's no issues with tolerability or toxicity. That's an easier recommendations, but we deal with these patients and their issues of tolerability and toxicity from years 1 through 5. So clearly those benefits and those issues in terms of tolerance, patient compliance is driven by it, extend to years 5 through 10. So when we roll out that, we have a trial or two that's really showing this benefit, we'd really like to be able to tailor it, particularly for the patients that are so intolerant. So when we try to make some of these decisions, and when I approach this with our patients in the clinic, I think, we kind of get a sense of their risk of relapse from some of our traditional features, so the lymph node positivity, and certainly the higher the number of lymph nodes, the greater the risk of recurrence, tumor size, stage of the disease at the time of initial presentation certainly play a key role. But then we have other features when we're really looking at how to incorporate patient age, their menopausal status, their other comorbid conditions, and then what is the initial adjuvant therapy that we're talking about potentially extending. So the Atlas and Adam trial was an extension of the tamoxifen data, but not all patients are initiated on tamoxifen in the adjuvant setting, and I think that really describes a premenopausal patient population. So, it doesn't quite address where we are with the extended recommendations for the aromatase inhibitors for those that get started on that in the adjuvant setting and now are approaching years 5 through 10. Or is there the issue with the sequencing? That works well if you start with tamoxifen, but how long do you continue beyond that? Now with the recommendations, you just extend your AI therapy for 3 to 5 years and make that a 7-year plan, or do we go on to do this extended 10-year plan for that? And I think it's important, that patients participate in these discussions. And, I think all of us have a varied patient population. I have patients that I certainly feel are at a very low risk. Those are often the patients that don't mind staying on it, and they tell me, oh, if there's some benefit, I don't care, I'm not having any problems, I'll do 10 years. Sometimes it seems to be mismatched. My patients that are at higher risk may say, oh, I'm just not tolerating this, and I'm giving them several other medications to go through some of the side effects. Those are the patients that want to come off of the therapy, but they're still motivated to do what's best to reduce their risk of recurrence. And so some of these tools, like the BCI index, I think has been quite beneficial. And then I think we come down to cost. And while cost of the medication, of extending the endocrine therapy is just a portion of it, the ancillary meds that a patient takes to stay on that extended therapy, then the issues with monitoring, the bone density, and then the recommendations for the bisphosphonates or bone targeting agents, the endometrial monitoring. So it becomes more than just the cost of the medication. I think the visits change. A patient may have gone on to an annual visit at year 5, but now if they're on extended therapy, they'll need to be monitored and prescribed. So it becomes even a larger issue when you think of all the other features and costs that wrap into that recommendation. So, and I think when we look at all these features, none of them really do provide a way of giving an individual risk of late recurrence for these patients that we've had to hand when we look at a list of tumor features, patient factors, and age. So the tool has become quite helpful, I think, in trying to carve out a niche that may be appropriate to have this sent on patients. So when we look at a landscape of the molecular tools to really help us with these treatment decisions, we have the tools available here on the chart you can see that are been incorporated in trying to make various decisions years 0 through 5, which really focus a lot on chemo benefit, much less on an endocrine benefit and risk of the disease as a prognostic tool. When we go out for years 5 through 10, we really see the breast cancer index and then Prosigna with its recent new application of being able to provide prognostic. But in terms of endocrine benefit as extended therapy recommendations from year 5 to 10, I think the breast cancer index has really carved itself out as a potential tool that we can incorporate when we have these discussions now as these patients start returning at year 5 to decide what's appropriate for their 5 to 10 year endocrine management. So I think it kind of comes back then to, well, what is this breast cancer index? And Dr. Pustai has really gone over what's been behind the 5-gene component for the prognostic and then the 2-gene evaluation for the predictive, and how we've come to utilize these together to put a score of which we have something now to decide upon in front of a patient that may help with that decision-making tool. So what I've done is pulled a couple of cases from my clinic, and I'll talk through just, how I've utilized it in some of my patients, and how I've, found some of this to be quite useful. So here's a patient who's 55 years old now. She was diagnosed about 5 years ago with a early stage, low grade, 1.4 centimeter adenocarcinoma. Had some evidence of perineural invasion. It was ER positive, node negative, HER2 negative. She did not receive any cytotoxic chemotherapy, went on to tamoxifen therapy. And the question comes now, at year 5 with the data with the Atlas and Atom trial, what we were going to do. And so, I had the discussion with the patient that there was newer data. There wasn't a subgroup that really didn't benefit from extended tamoxifen therapy as a group from that trial. But we did have another tool to figure out whether she would be more likely or less likely to benefit from another 5 years of endocrine therapy. So this is actually her breast cancer index report, and you can see she came back as a low risk, which I might have predicted, and had a low likelihood of benefited from extended adjuvant endocrine therapy. And of course, I think this really made her day, because when she started on her treatment, the plan was 5 years. So as she's coming in and has this on her calendar, and then I'm introducing, well, there's a study update, there's a potential benefit now from extended endocrine. It's not just limited to node positive patients. Again, I think there's that concern while a patient would do this and be compliant if it was absolutely necessary. I think this was very helpful for her to feel comfortable that she'd taken her 5 years, she had a low likelihood of benefiting, a low score, and she elected to discontinue any recommendation of extended adjuvant therapy, and I was very comfortable with that as well. So this patient, the second patient, is a little bit different of a patient. She's a little bit younger, earlier in her disease course. She was just diagnosed in July 2011, a little bit bigger of a tumor, intermediate grade, some different, luminal B-type features, ER positive, PR low. She was HER2 negative. She was actually treated on a clinical trial and received Taxotere and Cytoxan for 6 cycles and then initiated on tamoxifen therapy. So you might ask, well, she's not at 5 years, we're not there, she's not clearly menopausal yet, and why was I testing her 2 years into her therapy? Well, it's quite interesting. She was about to get married, and she kind of wanted to be very upfront and transparent and relay her entire medical history and recommendations as she was embarking on the next phase of her life. And so she asked about, well, how long am I going to be on treatment? And I, again, said, well, there's new recommendations, for extended tamoxifen therapy. She's about to get married. She's having issues with regards to tolerating tamoxifen, vaginal atrophy and issues. So we sent off the breast cancer index for her. And for her, she ended up being high risk. And I think it was very informative for her with a high likelihood of benefiting. So she's, felt that she was being very upfront with her fiance that this would be an extended course and we would have to manage the side effects as a young married woman in terms of the anti-estrogen properties and intolerabilities she was experiencing. So it was very, I think, helpful for her to be fully transparent as she was moving into another phase of her life, being upfront with what her health care recommendations were. Here's another case of a premenopausal stage 2 patient with a 2.5 centimeter. And she had a low oncotype score up front with a low risk score at 10. She went on to tamoxifen and had a lot of issues tolerating it. So as we were getting on her score, she was a pharmacist. We had done some of the CYP2D6. I mean, she was coming in every other visit, bringing me some paper that she had found, sort of getting ready to want to stop her tamoxifen. So for this patient, we went ahead and also had this discussion and sent off her BCI. And it's interesting, hers came out as an intermediate risk. which tracks really like the high-risk patient, and she had a low likelihood of benefiting from extended therapy. So it's quite a challenge, and she's a very bright young lady. So we sat down, and obviously you always want the test to have the result that you want, that is the tiebreaker. It ends a decision that you're low risk or high risk. But we talked about the intermediate risk, tracking more as a high risk, low likelihood of benefiting, but we didn't really have anything else to offer her. And she's elected to continue with the recommendations based on the Atlas and Adam trial to continue with her tamoxifen therapy. And I think, for her it was very valuable because I think she kept looking for some other measure to give her, I guess, a sense of complying with prolonged endocrine therapy now for a 10-year period. And then this final case is a little bit different. This is an older patient in terms of menopausal status. It's a postmenopausal patient, a low stage 1, 1.5 centimeter, again, a grade 2 lesion, ER/PR positive, and HER2 positive, which is not one of the genes in the assessment. She was node negative. She received her therapy with Herceptin. She was initiated on anti-estrogen therapy. Had difficulties tolerating this in terms of with her aromatase inhibitor, switching it. She's having issues of vaginal atrophy, having multiple UTIs. And so the question for her was, well, I've heard this data, and we had discussed, the data is not quite applicable to a patient who's on an aromatase inhibitor for 5 years, although I think we all, have a suggestion that when the data of these trials report prolonged endocrine therapy, whether it's an aromatase inhibitor or tamoxifen followed by aromatase inhibitor, most likely will yield that same benefit. It only makes sense in that setting. But for her, her BCI score was quite low, which she was quite happy to embrace, and suggesting that she would have a low likelihood of benefiting from an extended course of therapy. And so this patient, was very happy to embrace that. It was, I think, an issue of whether she would have been compliant with prolonged therapy recommendations and the difficulties of that with an aromatase inhibitor, but she elected to be very comfortable with the plan of discontinuing her therapy. So I think as we step back, it's just a little thumbnail shot of some patients that, are in my clinic and how I utilize this score. And I certainly don't roll this out to every patient. I think, there are patients who are clearly, whether they had a high score and a high likelihood of benefiting, that's not going to do anti-estrogen therapy for an extended time. And some that have comorbid conditions that it's not of ability for them to tolerate these recommendations. But we find that the low risk, low likelihood is about 50% when you send these out, these results. And the high risk, high likely benefit incorporates about 25%. And then there's a smattering of our high risk, low likelihood and the low risk, high likelihood. And I think these are all physician-patient discussions of where we have data, where we don't have data, and whether it is appropriate to continue therapy for these patients or not. So I think in summary, looking at, trying to really get some patient considerations in making that decisions from year 5 to 10, we really still try to individualize that. I know it's a long discussion that I have when I embark on that, and I start in year 4 for many of these patients to start planting that seed and seeing how the patients are tolerating, how many meds am I having to give them to stay on their anti-estrogen therapy. I look at where they are with their menopausal status. Did they start premenopausal? Are they now postmenopausal or perimenopausal? And I think regardless of whether they've had chemotherapy or not, this decision and discussion still is pertinent to each of these patients. And I think the BCI index has been very relevant and an important tool that has really helped in many of these determinations for specific patients in the clinic. So I guess at this point, I'll turn it over to our final speaker.
Thank you very much. So I'm Lily Shockney. I'm the co-founder and program director for AONN+, which stands for the Academy of Oncology Nurse and Patient Navigators. I'm also a 22-and-a-half-year breast cancer survivor, and it's hard for me to believe it's been that long ago, but it has been. And I'm going to be talking to you about the role of navigators and also give you a patient perspective as well. For my personal journey, I was diagnosed my first time in my 30s, a huge surprise, no known risk factors, no family history, but we know that 70% of patients have no known risk factors, and only about 12% have a family history. So I really fit into the majority when I look back at that. I had multicentric disease, though it was stage 1, and underwent a unilateral modified radical mastectomy followed by other treatment. I was ER negative then. I turned 40, and when I turned 40, I ended up with finding that I had breast cancer in my remaining contralateral side. Again, had multicentric disease, but I considered them fraternal twins because this time the tumor was ER positive. The majority of them were ER positive, I should say, and I did go on hormonal therapy, tamoxifen, and was also placed on megestrol at the same time for 5 years, and I felt like I had gone to war with my own body. It was a challenging time. My husband was incredibly patient. It's a life-altering experience, and believe me, for any patient that you're taking care of, it is a life-altering experience. I had been in oncology nursing for more than a decade when I was diagnosed, and I still look back at this has been the most profound experience I've had is dealing with cancer. I decided to have delayed reconstruction done. I wasn't initially a candidate for other medical reasons, so it was a decade after my second mastectomy when I did undergo reconstruction, deep flap reconstruction, and there wasn't an advocate for me to talk to. And oncology nurse navigators are patient advocates, very much so. But there wasn't a Lily Shockney for Lily Shockney. And I struggled with the decision about being away from work, not being with patients that I normally would have been seeing and navigating through. So when I asked my husband, do you think I should have reconstruction? And he said, I don't want you to do anything that you don't have to do because I've seen you really sick. My daughter was the same way. She was in her 20s. So I decided to change my profession. I have specialized with glioblastoma patients. So I stayed in the Bs and went from brain to breast and have been very happy in that role now for 2 decades. And I think it's the right fit for me. I do advise patients, make more time for yourself, steal out some personal time. You're in touch with your mortality. You deserve to have time for you. I went the other direction with that and committed that I'm going to give my life 24/7 to be supporting other individuals who end up wearing my bra in the future. And a little over 5 years ago, I founded this Academy of Oncology Nurse and Patient Navigators because nurse navigation is a growing profession and it didn't have a home professionally as an organization. This organization has over 5,000 members. We have now more than 21 local chapters and they're growing, which I'm excited about. And where do we practice? We're all over the country. We also have international members as well from Canada and elsewhere. 40% of nurse navigators are in a community setting where the majority of cancer care is delivered. 20% are purely in an academic setting, and 13% are in community teaching hospitals. And our role, we participate in about 90% of breast cancer tumor boards, and actually most of the time are the primary scribe, the one that compiles the cases to then subsequently be presented. We also support those patients to make sure that their voice is being heard. So if the case is being presented very clinically, I'm likely the one that's going to say, and by the way, she's a 5th grade school teacher and she has an 11-year-old boy who has autism, just because we should be treating more than her pathology. We should really know who this patient is. From the point at which when consultation between the navigator and the oncology team takes place is usually at the point of diagnosis, definitely as they begin undergoing treatment. 27% are prior to treatment, just as they're getting the news that they have a positive biopsy. And 30% of navigators are seeing the patient through the entire continuum from point of diagnosis through to end of life or long-term survivorship. The average nurse follows about 45 diagnosed patients a month. From a survivorship program perspective, I'm sure none of you are surprised by this, or I hope you're not surprised by this. The American College of Surgeons, with the Commission on Cancer, and they, as you know, conduct the triannual survey for cancer centers that are accredited by that organization have added some new standards that get implemented in about 2.5 weeks. One of those is related to survivorship care plans. In the acknowledgement that we have a shortage of oncology specialists and a growing incidence of the number of people diagnosed and surviving cancer, there is a need for us to begin transitioning patients back to their community physicians. That includes our breast cancer survivors, which is a huge population of individuals. So for those from stage 0 to 3, we do need to be providing them a treatment summary as well as a survivorship care plan. For this first year, 2015, the expectation is that 10% of the cancer patients that are being treated at that cancer center need to have these documents in hand. The majority of institutions, which is no surprise, are utilizing the breast population because that was where all of this started, and so that oftentimes is the place that it will also become expanded to. And listed on this slide are the required data elements of that treatment summary as well as that survivorship care plan. Patients that are hormone receptor positive are the ones that obviously are going to be going on hormonal therapy, and they want to know, how long do I need to take this drug? For a long time, obviously, we said 5 years. Well, now we're saying something different, and we're saying 10 years. I find it intriguing, because I've taken care of a lot of patients in my career, and when it comes to chemotherapy, they want to know which drugs work the best. When it comes to hormonal therapy, they ask me which drug has the least side effect. So they ask me which one works the best, because they're seeing this as a long-term commitment and they want to balance it with quality of life, which I can appreciate. Oh, I see what it's doing. Whoops. So the role of the oncology nurse navigator from the perspective of survivorship care, working with the multidisciplinary team, we do try to dovetail the patient's life goals with the treatment plan. That's the first thing that I ask the patient, is tell me your life goals before you heard the words you had breast cancer. Usually they'll say, it doesn't matter, just save my life. And I'll say, I think your life will be saved and I want to know what they are. So if a patient was planning to start a family in a year or two, and we know that we're going to be giving her systemic treatment that might put her ovaries permanently to sleep, we want to get her into fertility preservation even before we put a port in her. If a patient is employed as a secretary, and I had such an individual a couple months ago working at a bank, as I asked her where she worked, and when I asked her about her life goals, and she said, well, actually, I'm studying to be a concert pianist. That's my passion. So I was on the horn to the medical oncologist she was to see 2 days later and said, if you can keep away from her drugs that we know will cause peripheral neuropathy, that would be a good thing. Otherwise, we're going to steal away her career goal. And that means that she's sacrificing a whole lot more for cancer than what she should have to. Oncology nurse navigators are front and center with identifying barriers that may impede the patient from getting treated, including treated in a timely manner, and making sure that that treatment is complete, delivered in an efficient way, and in keeping with NCCN treatment guidelines. And we try to provide solutions to these barriers. The number one barrier in the United States is transportation, not having the ability to get back and forth from their home or from work to the facility where they need to get their treatment. And the other is financial, which is a growing problem. As we see more deductibles and copays, that's going to become a bigger problem. Prescription assistance is more needed now than ever. And again, that is the role of the navigator to find out if this particular patient will need some financial support in that regard. And synchronizing the treatment plan with the patient's work schedule. The majority of individuals with breast cancer are diagnosed while they are working full-time. They find it more and more difficult to take off big blocks of time from work because they don't have a lot of time saved up. Nobody plans to get this disease, or certainly not many. So being able to support them and saying, let's arrange for your radiation to be 7:30 in the morning rather than 2 p.m. in the afternoon so you can still go on into work afterwards. Having your chemo on Friday afternoon instead of on Wednesday, again, so that those side effects happen over the weekend. Patient education, very important, and I think that probably the most hours of a navigator are spent doing that, as well as psychosocial support for the patient, as well as the family members that are also impacted by her diagnoses. And we promote adherence to treatment, especially oral medications, because we are dependent on that patient taking the medicine as prescribed, and they are not being seen each time that they're taking that pill. It actually seemed easier when we were doing all IV infusions. We had control. I love control. But obviously oral therapy, thank heavens, is designed for the patient to be able to manage on their own. Also providing them referrals to other resources that they may need. For example, where can they get a free wig, or do they want to be part of a support group and talk with others? I think the most important role of all, though, that we have is being the advocate for the patient and making sure that her voice is heard. Serving as that recorder and coordinator, as I mentioned, for the tumor board meetings, and educating and preparing patients for short and long-term survivorship, letting them know at that first consultation an expectation as to how this continuum of care will likely play out, how decisions will be made and when those decisions happen, what data is used to effect those decisions, and prepare them to transition back to their community physicians so that it's not a surprise when they finish their acute treatment. As well as promoting healthy lifestyles. And this is an opportunity when patients have phospho-religion when they've been diagnosed. So we can persuade them to do just about anything. If we can get them into a groove of a healthier lifestyle during their treatment, then there's even better odds that they will maintain this. Safety and tolerability with endocrine therapy. I know that you've seen this. You also heard some of this information as well. This is a big challenge, and side effects is the biggest driver as to why patients do not comply with taking their hormone therapy as prescribed. And recognizing that these side effects we may think aren't a big deal, but if they are a big deal to her, then they are a big deal. Extended endocrine therapy is often positioned as less difficult to take than chemotherapy, when in fact it may not be. And again, it goes back to we're not there to be the reminders of that patient of the importance of taking this pill every day. And as I said, you know, which chemotherapy works best? They want that. But when it comes to hormone therapy, they're not saying which one works best, because they're looking at this as a long-term investment, and they have to balance that with quality of life if they can. So our goal is not just survival anymore, but it's survival with quality of life. And if we aren't trying to achieve that for her, I believe we have failed her. And in looking at this about the timing of when a patient arbitrarily begins discontinuing their medications, and these are patients that we believe have told us the truth, I think is also important to recognize. Usually we'll ask the patient, are you taking your hormonal therapy? Yes. We don't say, are you taking it as prescribed? Are you having any difficulty taking it? Is there any side effects that I can help you with? It's just, are you taking it? And they go, yes, because they are. They're just not taking it as we ask them to. They're taking it every other day or every third day, or take it this month, not next month. So compliance and adherence to endocrine therapy certainly we know impacts patient outcomes, has been proven via clinical research. So inspiring that patient to do the right thing, it needs to be based on some solid data that validates for them they really do benefit from taking this medication. So with endocrine therapy and its extension, patients fall into two groups. I can't wait to finish. Most follow into this group, I'll tell you. I've had it marked on my calendar. Probably your spouse has also had it marked on the calendar. But those that are really frightened, that are doing a self-breast exam in the shower every morning, they have toe pain, they think they have toe cancer, they are not enjoying their life. They're the ones that are saying, this pill I believe is keeping me alive. Please don't take it away from me. Please, I don't want to stop this medication. But if we can provide some objective scientific tools that can help determine who needs to stay and who does not need to stay on this drug long term, that would be incredibly helpful. When the news came out about extending things for 10 years, and I told my husband, I said, well, you know, if we were back 20 years, we'd be having a discussion about me taking hormonal therapy for 10 years. And he went, oh, wow. And I said, yeah, I said, somebody would really have to prove to me that I would need to take it for 10 years. And I'm an oncology nurse trying to promote it, right, trying to get patients to take it. But having been a patient, I know how hard it is to take it too. Determining the length of time for a breast cancer survivor to take hormone therapy. Patients without side effects are comfortable staying on a drug. Patients that are experiencing side effects, they want proof that they need to take this medication. The survivorship care plan needs to contain information regarding their hormone therapy and how long they're going to be taking this, how to manage side effects, and if they have new side effects, how to also inform us about those to see if we can assist them with it, how to help them adhere, which might be associated with forgetfulness. Might be that they aren't used to taking any medicines at all. This is a new thing that they're factoring into their lifestyle. So it may require a pill counter, et cetera. How to minimize some of their menopausal symptoms, too, they need to know. And the PCP needs to know how to support the patient to adhere to hormonal therapy as well. And if this patient is going to be on for 10 years, we do need that healthcare provider to be assisting us in keeping her on track because she remains at increased risk of getting this disease. And I think we're going to open up with questions now.